Definitely do that. So we're going to be talking a little bit today about eating disorders and specifically how it relates to perfectionism and different treatment modalities and just different ways to approach them clinically. So just a quick tidbit about myself. I am a core faculty member at Liberty University. And then I also have a private practice in Huntersville, North Carolina. So we're going to work today to establish a basic knowledge of eating disorders and their comorbidities, as well as establish a basic understanding of perfectionism and its ability to be either maladaptive or adaptive in regards to eating disorders and their treatment. And then also applying different treatment modalities and specific interventions aimed at perfectionism and disordered eating. So just some statistics in regards to mental illness. Eating disorders have one of the highest mortality rates of any mental illness. 1 in 5 anorexia deaths is actually deaths by suicide, and we'll talk a little bit about specifically what that means. 1 in 10 bulimia patients has a comorbid substance abuse disorder as well. And just some other statistics regarding anorexia, binge eating. I venture to guess that this number is higher now, and that some of these numbers have changed, in the midst of a pandemic. So I'm going to skip over these ones. So we're just going to jump right into diagnostic criteria for various eating disorders. So when we're talking about anorexia specifically, in regards to diagnostic criteria, it's defined as persistent restriction of energy intake. And it's important that we also recognize that this leads to significantly low body weight, because body weight is one of the diagnostic markers for anorexia nervosa. So there needs to be that persistent restriction of caloric intake. Individuals with anorexia also endorse an intense fear of gaining weight, becoming fat. There's this persistent behavior that interferes with weight gain. So keeping a low body weight and not gaining weight is a persistent behavior. They also experience disturbance in the way that they experience their body related to weight and shape. So that essentially means that they do not accurately experience their body. They feel larger or different than they actually are, which leads to a lot of the disordered behaviors and disordered thought processes. So in regards to subtypes, there is the restricting type, which the restricting type of anorexia, there's no binge eating, no purging behaviors, and weight loss is accomplished primarily through restricting. So through dieting, fasting, excessive exercise. When we switched from DSM-4 to DSM-5, one of the changes was the addition of binge eating, purging type anorexia. And with this type of anorexia, there is the presence of binge eating and use of compensatory behaviors. So that could be laxatives, diet pill use, purging. We were seeing that there was some overlap between some of the diagnostic criteria between anorexia nervosa and bulimia nervosa. So seeing some of those binge eating and purging behaviors in anorexia is one of the changes that was made. So in regards to level of severity when we are diagnosing anorexia, it's based on BMI, which a lot of clinicians and dietitians that work with eating disorders have a little bit of an issue with this, but it is kind of what it is. I don't really like BMI as a diagnostic marker, but that's how we determine level of severity. So when we're looking at signs and symptoms of anorexia, we're looking for some of the classic signs and symptoms: skipping meals, food rituals, obsession with calorie counting. Unfortunately, this has become so easy now with smartphones and different apps. You can literally scan a barcode on a food item and it tells you how many calories, how many macronutrients and micronutrients in one serving. And calorie counting and tracking has become so easy yet so detrimental for individuals with anorexia. Excessive exercise, body checking. When I talk about body checking, I mean like excessive looking in the mirror, excessive measuring of their body, measuring of inches of arms, thighs, waist, bust, just anything. I would have a client that would sit on my couch in my office and just regularly be just kind of touching her arms and pinching her skin to see if she felt larger than she did the day before. We see a lot of medical concerns related to slow heart rate, low blood pressure, a lot of muscle loss and weakness, dry skin, hair loss, a lot of GI issues due to restricting caloric intake. In the DSM-4, amenorrhea or loss of menstrual cycle used to be a diagnostic marker, but we've taken that away as a diagnostic marker with DSM-5. It's still a sign and symptom, but since men don't have periods, we were excluding them from that diagnosis, with that being diagnostic criteria. So it's no longer a diagnostic criteria. And we are seeing increased eating disorders in the male population as well. Comorbidities seen with anorexia, a lot of anxiety, depression, OCD as a manifestation of anxiety or as the manifestation of the eating disorder. And then we see some of our cluster A and C personality disorders, and a lot of social anxiety, social phobia. Bulimia nervosa, on the other hand, when we're looking at diagnostic criteria, we're looking at recurrent episodes of binge eating. So that would be eating a large amount of food in a very discrete period of time, feeling lack of control over eating. It's really important when we're talking to clients about their binges that we realize that binges are subjective. So what one client might consider a binge may be very different from what another client considers a binge episode eating. So we need to be aware of that and determine what that binge behavior is for each client. We also see recurrent compensatory behaviors here. So purging, laxative abuse, excessive exercise. One common myth is, can you diagnose bulimia nervosa without actual purging? And yes, you can, because one of those compensatory behaviors can be excessive exercise or laxative abuse. For diagnosing, we're looking at periods of 3 months. So we're looking for episodes of binge eating at least once a week for 3 months. Individuals also endorse a disturbance in the way they experience their body. So again, that unrealistic view of how they are in reality, how they appear. And to diagnose level of severity with bulimia, we are looking at the number of episodes of use of compensatory behavior. So looking at how often they're purging or participating in that excessive exercise or utilizing or abusing laxatives. Signs and symptoms here, we see a lot of electrolyte imbalances. So it's really important that we work closely with medical providers to get accurate blood work and to monitor because we do see a lot of electrolyte imbalances, a lot of eating in secret, a lot of frequent trips to the bathroom if they're purging or abusing laxatives, compulsive behaviors. Often some of our dentists are some of the first to recognize bulimia with tooth decay or inflammation of the esophagus.
I don't think I'm bipolar.
All right. And when we're talking about comorbidities for bulimia nervosa, we're also seeing anxiety, depression, substance use, and then more of our cluster B personality disorders. So borderline personality disorder, and then bipolar disorder. One thing that I noticed when working with clients with bipolar and bulimia nervosa is that their episodes, their manic and depressive episodes would align with their symptom use, their eating disorder symptom use. So that was one thing to monitor as well. And then also with individuals who had comorbid substance use, we would see that when they were clean and sober and not using their substances, they were more likely to use their eating disorder behaviors. whereas when they weren't using their eating disorder behaviors, they were more likely to be using substances. Again, because both are maladaptive coping skills, and they would kind of switch from one to the other. Binge eating disorder was a new addition with DSM-5 and is one of the most common eating disorders. So here we're seeing recurrent episodes of binge eating, again, eating larger amounts of food than normal in a discrete period of time, feeling that lack of control. Again, these binges are very subjective, so we have to talk with our clients and understand what they consider a binge. And then they also need 3 or more of the other criteria, which is eating more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not physically hungry, eating alone due to shame or embarrassment, and feeling disgusted with self or guilty or depressed afterwards. So there's definitely a marked level of distress with these clients. It's definitely impacting their daily life. Here, the level of severity is based on the number of episodes. Number of binge eating episodes. Weight is not an indicator or diagnostic marker for binge eating disorder. And then as opposed to anorexia and bulimia, individuals with binge eating disorder actually see their bodies and experience their bodies accurately. So there's no over-evaluation of their weight and their shape. Again, like I said, it's the most common eating disorder, and there are a lot of health risks related to obesity. So a lot of cardiac problems, kidney problems, diabetes, some cancers, sleep apnea. We also see comorbidities with anxiety, depression, substance abuse, and bipolar disorder. So when I think of eating disorders, I like this image because it talks about a continuum. And on one end of the continuum, we have healthy body image. So we have body acceptance, healthy, relatively normal eating habits, healthy weight for age, height, and body type. And this is one end of the spectrum or the continuum. And then on the complete opposite end is where we see anorexia nervosa, bulimia nervosa, binge eating disorder. So our diagnosable eating disorders. And then in the middle, there's this really large gray area of disordered eating. So these are subclinical eating disorders that don't meet diagnostic criteria, but where that disordered eating really does impact the individual's life. And so we see restricting behaviors, we see purging behaviors, a lot of this striving for perfection physically, preoccupation with weight and shape. Pretty much everywhere you turn, any social media outlet that you're on, you will easily be bombarded with the latest workout trend, the latest diet trend, different eating plans, different apps that help you to get in shape or lose weight or change how you eat. So it's very prominent and very in our face in our society. And, you know, we oftentimes will see clients who may not be in this diagnosable on this diagnosable end of the spectrum or the continuum, but they're more in this middle area where they're using food, they're using exercise as a maladaptive coping skill, and it's leading to some disordered eating or disordered thoughts when it comes to food and body and exercise. And so what causes eating disorders? What makes an individual prone to eating disorders, or is there such a thing? And we see a lot of biological factors. So genetics actually play a huge role. Approximately 80% of individuals with an eating disorder, so with a formal diagnosis, have a family history of eating disorders or disordered eating of some sort. There are biological factors that predispose individuals to the inability to regulate their appetite or their mood or their sleep or their stress, which all impacts disordered eating behavior. We see increased levels of cortisol, which is the stress hormone, in individuals with anorexia and bulimia, and then also increased levels of serotonin. So there are a lot of biological factors that contribute to disordered eating behaviors. In regard to psychological factors, we see a lot of low self-esteem, difficulty regulating emotions. We've heard people talk about emotional eating, and that really is a subset of eating disorders, disordered eating behaviors, when we are trying to suppress those emotions, turning to food or to exercise. So there's a fine line between, when exercise and food become self-care or maladaptive behaviors. We see a high level of impulsivity, specifically in bulimia nervosa, and a higher level of perfectionism, which we're going to talk about more with anorexia. Psychosocial factors that contribute. We see a lot of trauma history in our individuals with eating disorders, sexual abuse, physical abuse, verbal abuse. We used to think of eating disorders as purely, peer pressure, societal expectation type of mental illness, where the focus was just on being thin and beautiful and having the right body type. And that's definitely still a pressure and still a contributing factor. But we definitely see a lot more social and family and just trauma history factors that play into eating disorders. So some general treatment goals. One of the primary goals is to normalize eating and the client's relationship with food. Oftentimes we can compare treatment of eating disorders to substance abuse treatment, and they do have some similarities, but with substance use, you can, one of the treatment goals can be abstinence, it can be elimination, but we can't totally eliminate food from our lives. So the treatment goal has to become normalizing eating and the client's relationship with food, really seeing food as an essential fuel to keep our bodies and our minds healthy, and working to create a better relationship with food. Decreasing and eliminating eating disorder behaviors. Ultimately, we would like to eliminate eating disorder behaviors and not have a client ever struggle again. But for some, that's just not realistic. And it's more realistic to look at decreasing those behaviors. We're going to look at weight restoration because there are certain biological processes that don't occur when an individual isn't at a minimum weight or a healthy weight. So for example, with women and having our menstrual cycles, our body kind of has to we have to be at a certain weight for that process to be restored. So looking at weight restoration, medical stabilization when appropriate. And then we want to look at decreasing the impact of comorbidities. So look at treating the anxiety and the depression and any other mental illness that may be present. We're also going to look at increasing supports. Eating disorders in and of themselves can be very isolating. So it's important to look at increasing family and peer supports and improving interpersonal relationships. Best practice recommends a multidisciplinary approach to treating eating disorders. So it's really important that we as clinicians are working with medical providers as part of the multidisciplinary treatment team to monitor, again, that blood work, monitor that weight, monitor any other medical comorbidities that may exist. It's important to work with a dietitian who can help the individual, again, with creating that healthy relationship with food in a more practical way. So what are some meal options? What are some, good calorie ranges, healthy calorie ranges that you need to be in to restore any weight loss that's occurred? Our job is to provide that psychotherapy, that clinical processing, and then also working with psychiatry to make sure that medications are managed and that the individual is on appropriate medications that don't interfere with any medical treatment or clinical treatment that we're providing. It's really important to, when you're working as a multidisciplinary team, to really respect each other's scope of practice and collaborate with one another and having that ongoing communication. So when we're talking about different theories and interventions, CBT is one of the most widely used. It's the evidence-based practice for treating eating disorders. It addresses the comorbidities really well. It addresses harmful behaviors and maladaptive beliefs that are, seen with anorexia and bulimia. Again, addresses those inappropriate coping skills and the different cognitive distortions that are present. And it really encourages a collaborative approach to the therapeutic relationship. We also use a lot of DBT in the treatment of eating disorders. DBT does a really good job of integrating mindfulness and acceptance strategies, and really helps to address that affect dysregulation that's present. DBT is also well utilized when there's a comorbid borderline personality disorder diagnosis. And then it also addresses the maladaptive behaviors, the eating disorder symptom use, so the binging, the purging. We see a high level of self-harm also with eating disorders, so DBT does well to address that. And DBT is really good at exploring, issues related to compliance and resistance. So when we have individuals who are not compliant with their meal plans or with their treatment plans and are really resistant, DBT is well utilized there as well. I really like this specific tool. We utilized it when I worked in a residential and an outpatient treatment facility. It's called the behavior chain analysis. And we could use this with clients when they reported using their eating disorder behaviors and helping them to assess what led to using those behaviors. So we could look at what was the vulnerability that took place. So maybe the vulnerability was they were just having a rough day. They were tired and having a rough day. And then what was that prompting event? The prompting event might be a fight with a significant other. And then what thoughts, feelings, and behaviors did they have? So maybe that caused them to think that it was just a terrible day and they were a failure. And then it led to feelings of defeat or anxiety that then led to their behavior use. And then you can help them kind of see the links and see the consequences and determine, okay, where can I, when I'm feeling vulnerable, what can I do so that I don't go down this road again? Or, when I'm feeling vulnerable and this prompting event happens, who can I reach out to so that I don't go further down this road and use my behaviors? So it's really helpful to help them see how it's all linked together and their eating disorder symptom use isn't isolated. Other therapeutic techniques and interventions, equine therapy is really helpful in and is being used in the treatment of eating disorders. Animal assisted therapy is another one that's used to decrease anxiety. Yoga and movement therapy has been used a lot in the treatment of eating disorders because we see that there is a decrease in that mind-body connection. Individuals with eating disorders almost purposely cut off that mind-body connection because they don't like the way that they're experiencing their body. They're not comfortable with their body. And so as we're addressing the behavior use, as we are helping them develop a healthier relationship with food, we also have to help them create that mind-body connection again and to really learn to enjoy food or enjoy their body and be present in their body. So that's helpful as well. And then we also see the use of expressive arts and music therapy. So this really empowers clients and again, can contribute to that mind-body connection. We see a lot of clients who are unable to kind of verbally process and express what they're struggling with. And when we utilize expressive arts and music therapy, that gives them another avenue to express what they're struggling with. So the therapeutic process is really important in treating eating disorders. It's really important to define the role in the therapist of the patient and the therapist in that framework. It's really important to allow the patient to kind of conceptualize their problem. So kind of help them see how different events in their life have brought them to where they are, and how it's related. And it's really good for us to model helping them develop that interpersonal relationship. Like I said, a lot of eating disorders are very isolating, so helping them to increase their interpersonal relationship skills is important. Research shows that the strength and quality of the therapeutic alliance positively impacts outcomes in the treatment of eating disorders. So we see that therapeutic bond is more significant than the particular interventions used. Clients with different attachment styles, specifically anxious attachment, benefit from establishing that strong therapeutic alliance, and it helps to encourage them to self-disclose, and really leads to good treatment outcomes. So creating that safe environment, that place where the individual can self-disclose, self-explore, is really important, and not just with eating disorders, with all counseling in general. We see a lot of resistance sometimes in treating eating disorders. So it's really helpful to develop that strong therapeutic relationship to prevent that resistance. It's helpful to assist the clients in understanding the root of their eating disorder, what's underneath it. We can address just the eating disorder behaviors, but if we don't address the root of what's really under the eating disorder, which may be anxiety or depression or some sort of trauma, if we don't address that, the behaviors will just manifest repeatedly with eating disorder behaviors or in some other way. So again, addressing that root cause. Creating and increasing their awareness of their eating disorder behaviors. For some of them, they've become so habitual that they don't even realize what they're doing anymore. And then helping them identify replacement behaviors, instead of using their eating disorder behavior, giving them a positive coping skill. Encouraging cognitive flexibility, specifically with anorexia. Their way of thinking is so rigid that that cognitive flexibility is just so hard for them to grasp, and so hard for them to think that things are not just black and white. So to encourage that gray level of thinking. Using a lot of motivational interviewing techniques is helpful. So challenging while supporting, teaching some distress tolerance. These are all therapeutic interventions that work really well when we're working with eating disorders, specifically individuals who are pretty resistant. It's important to help clients develop a strong sense of self. Again, so much of their self-worth and self-identity is wrapped up in their eating disorder. So helping them develop that strong sense of self outside of their eating disorder is very important. I like this model as well. I like stages of change model applied to eating disorder treatment. I think so often individuals that initially come to treatment, specifically with inpatient or residential treatment, might not be ready to be there, don't want to be there. They're there because their medical provider has said they need to be, or family members force them to be there. And so working through the different stages of change and where they are and coming alongside them is really important. And, talking to them and processing through that relapse may likely occur and will probably occur, and that's okay. But if you relapse, how do you get back on and go in the right path again? All right, so I want to talk a little bit about eating disorders and perfectionism. There's this complex relationship that we see, and I started noticing this when working with clients, that a lot of individuals with eating disorders, specifically anorexia, were also endorsing perfectionism, and we're really struggling with perfectionism in all aspects of their life, even perfectionism in their eating disorder. And so looking at perfectionism, there's a distinction between socially prescribed perfectionism and self-oriented perfectionism. So socially prescribed perfectionism is these demands, these ideas that we need to be a certain way, fit a certain mold, and this external pressure that is put on individuals. Whereas self-oriented perfectionism is more of an internal type of perfectionism, more of this internal belief that I have to be a certain way, this internal pressure. Individually, they're both, they can both be adaptive or maladaptive, but a combination of the two is the most maladaptive. So when we look at self-oriented perfectionism, specifically related to anorexia, we can see the perfectionistic tendencies in our clients. So we can see them, again, outside of the eating disorder as well as with the eating disorder itself. So one way of thinking is clients will label foods as good or bad. These are foods that are good that I'm allowed to have. These foods are bad. I'm not allowed to have them. They're not good. And really sticking very, black and white and very firmly to that. I can't eat bad foods. I can only eat good foods. Patterns of restricting and binging. These patterns of, if I eat 1,200 calories today, I have to do a certain number of calories of exercise to make up for it. And it becomes very perfectionistic, very all or nothing. There, again, it's that all or nothing, black and white thinking. There's not really a room for moderation. There's not room for that gray area. And it becomes very harmful to them. And again, it applies to a lot of areas of their life, not just their eating disorder. These individuals with this self-oriented perfectionism tend to be very high achieving. They're very driven. Again, they seek perfectionism in so many aspects of their life. I have had multiple clients who, one was an athlete. He was a track runner and he was very smart. He was also top of his class, got a scholarship to a major university to run, but also struggled with eating disorder behaviors. And so we see that they are high achieving. They do have very high expectations for themselves. Again, not just in their personal lives, but in their eating disorder as well. So again, often clients with this self-oriented perfectionism are very successful. They haven't really given themselves the option or the choice to not be successful. They have pretty high expectations of themselves. And if they don't achieve those expectations, whether they be realistic or not, this tends to lead to a lot of shame and guilt. And again, there's no gray area with that shame or guilt either. It's either I have perfectly achieved what I need to achieve, or I'm a complete and utter failure who doesn't really deserve to live. And so there's not much of a gray area there either. So, historically in our treatment of eating disorders, specifically where we see these perfectionistic tendencies or we see perfectionism, we say, oh, well, that's not positive. That's not a good thing. That's, dangerous to them. It's a part of their eating disorder, and those behaviors need to be gone. We need to rid our clients of their perfectionistic tendencies. But what we're coming to learn is, what if that perfectionism isn't all bad? Can we use that perfectionism in a positive way in treatment with these specific individuals? And so we have to really consider perfectionism as a multi-dimensional construct. We need to look at an individual's perfectionistic concerns or their inner critic and look at their perfectionistic striving. So what is it that they want to do? What is it that they expect themselves to do? When we talk about this inner critic in the eating disorder realm, we kind of call this their eating disorder voice. But this inner critic is often very harsh. Individuals will describe it as an abuser, almost like this just internal verbal abuse that's continuous. And individuals just can't seem to ignore or rid themselves of this inner critic. So they often describe that their eating disorder voice or their inner critic criticizes their lack of willpower. So if you don't stick to the 1,200 calories a day that you're allotted, you're just a terrible failure because you have no willpower. Their inner critic will attack their self-esteem, attack their physical appearance. These are those thoughts, those eating disorder thoughts of I'm not small enough, or I don't have a big enough thigh gap, or the thoughts just go on and on, and just really lead to harsh thoughts and beliefs about themselves. So treatment of eating disorders has to address that inner critic and the perfectionistic tendencies. We can't ignore that inner critic. And we have to really focus on differentiating between the two, because for so many, this inner critic has just become who they are, and they don't even really recognize the difference between their positive thoughts and their negative thoughts. And they just have become so harsh and so critical of themselves that they don't even recognize it anymore. So the goal here really becomes, how do we harness that individual's desire for high achievement while quieting their critical inner voice, right? Because if some of the perfectionistic tendencies that, led my client to be so successful in school or as an athlete weren't all bad. They were positive. They helped him grow. They helped him have, goals and stick to those goals. There was a lot of determination. So you don't want to tell a client, well, just stop being a high achiever, stop, wanting to get good grades, stop wanting to get this scholarship or get into this major university, just stop all of that. If you rid them of some of those tendencies, you're actually doing them a disservice. So how do you kind of help them, again, keep and harness that desire for high achievement, but not be so critical and quiet that critical inner voice? So here we really focus on creating realistic reframes. So challenging some of those maladaptive thoughts, challenging some of that black and white thinking, exploring that gray area a little bit more, exploring moderation, softening that inner critic's voice. So one intervention that we use is they would keep track of the negative thoughts or the inner critic voice that they would hear. And then they would write them down, and then we would work to challenge those and come up with comebacks, so to speak. How would you challenge that inner critic? What would you say in response to that inner critic? How do you quiet that inner critic and tell them that they're a liar and what they say is not true? Really focusing on progress, not outcomes. So again, it's not wrong for them to have these high achievement goals, but helping them focus on the journey to get there, the progress to get there, not necessarily the outcome. So if the outcome isn't what they wanted it to be, but they still made a lot of progress along the way, it's not all a waste. They're not a complete failure. And one of the biggest things to teach them is practicing that self-compassion. Self-compassion is so foreign to some of these individuals. They don't know what that looks like. They have to be taught that. They don't know what it's like to validate themselves or to practice self-care or self-compassion, because that critical, harsh, abusive inner voice is all that they hear. So I have a couple videos that I'll share if we have some time and I can figure out how to do it. But I just want to allow some time right now for some questions, trying to figure out how to get you guys back on my screen so I can see you. If anyone has any questions.
I have a question.
Yes.
So if there is are co-occurring disorders like the substance abuse or depression, which diagnosis would you work with first?
That's a good question, actually. I prefer, and what was modeled for me was treating them both. So there are some residential eating disorder treatment centers that focus on treating both the substance use and the eating disorder co-occurringly. And that's where it could also take, the use of a strong multidisciplinary team to address both of those at the same time. When I worked at a residential facility, we did group work. We actually had a substance use group. So part of their treatment was a substance use group.
Thank you.
Yeah. And I can't see the chat. So if other people have questions, feel free to turn your mic on and ask.
Would you say that you can apply these treatment modalities to pica rumination disorder or avoidant and restrictive food intake disorder?
Yeah, there are a lot of these treatment interventions and techniques that can be applied to the other eating disorders as well. And some of, the RFID or avoidant restrictive is some of that distress tolerance too, and some of that, self-awareness and that mind-body connection as well.
Thank you.
And also, do you know the percentage that the clients would go back to having those eating disorders or triggers? Is it like a really high percentage?
I don't know the exact number, but from the work that I've done and what I've seen with clients and kind of what I prepare clients for is you may never, and the likelihood that you'll ever be 100% fully recovered from your eating disorder is almost setting yourself up for failure, because I think that eating disorder voice, those thoughts and behaviors, they can always be there kind of looming in the background. And sometimes they're not really an issue, and we're strong and we're doing our work and we're in recovery and it's not an issue, but some of them can be triggered so easily that we have to really be aware of our triggers. So I think approaching it from the mindset of, this might be something that you live with for the rest of your life. That doesn't mean that you have to engage in the behaviors, and that doesn't mean it's always going to be as hard as it is. But just because so much of it is also, biologically driven, I think that it's realistic to think that tendency might always be there.
Okay, thank you.
Mm-hmm.
I have a question. And you might get to this, I'm not sure, but I wanted to know if you were wanting to get more trained and knowledgeable in eating disorders, what organizations or sites would you recommend?
Yeah, so there are a lot of different ones, and some of the statistics that I skipped over at the beginning because I was just trying to be aware of time. But NEDA, so the National Eating Disorder Association, is a good one. Another one is ANAD. And then IADEP is another one that's aimed for professionals. So you can actually get certified to be a certified eating disorder specialist. So going through different trainings and supervisions and receiving that credential.
Okay, thank you.
I actually have a question as well. My question is more so about clinicians, professionals who are either already working within the eating disorder capacity or interested in working within the capacity, and they themselves also have a history or currently are experiencing an eating disorder. Like, what feedback or recommendations you have for those professionals?
Yeah, and I don't know if this will surprise people or not, but in the field of eating disorders, there is an extremely high rate of clinicians who themselves have struggled with an eating disorder. And I think that's just because, when we struggle with something so profound, we as helpers in turn want to help, and it strikes us to want to help others. And I think it's really important. One of the biggest things that I've learned, because I did in high school struggle with an eating disorder, and that, the treatment that I received and the growth that I made is what prompted me I ended up getting my bachelor's in nutrition and then going on to get, my master's in counseling. And so I've always had a desire to work with eating disorders. But one thing that I've learned along the way is just having good accountability. So I have people in my life that know what I went through, know where I am now, and regularly will ask me, how are you doing? Having good boundaries and knowing, when am I feeling a little bit triggered? When is this all feeling a little too much or a little too heavy? When do I need to kind of step away a little bit? I found for myself that I enjoyed working in residential, and I enjoyed, working in intensive outpatient. But when it's all you're doing every day, it does become a lot, and you do have to be more kind of on your toes and more aware of your triggers, because you can so easily be triggered. So I would say, that transference, that countertransference, just really being aware and seeking your own help when you need to, and creating those strong boundaries, because that's in the helping profession, that's huge anyways, but specifically with eating disorders where we can so easily be triggered.
Awesome. Thank you so much.
Yeah. Yeah, and I think Amy mentioned the CBTE that was developed by Christopher Fairborn. So the CBT specifically for eating disorders. Other questions or thoughts?
I have one more question, if that's all right.
Absolutely.
I work at a university, and I've been seeing a lot more self-disclosures of potential eating disorders or disordered eating. And I've found the benefit of working with that collaborative team. We have a nurse practitioner on site, and then also just psychiatrists and whatnot. But in regards to that, that developmental age, would you have any recommendations, especially with you teaching at Liberty with college students? I didn't know if that's something that you come into contact with, whether as the professor role or counselor role, if you have any recommendations for working with college students.
Yeah, absolutely. And I, in my private practice, work with a lot of college students as well. And I think a lot of times that's where we see some of these behaviors kind of start to manifest a little more clearly. There's so much transition that occurs with, leaving home and then, going to college, being responsible for your own meals, your own food, not having that supervision lurking over you all the time. Again, the peer pressure, the standards for dress, all of that, or appearance, all of that kind of factors in. And I think some of the universities that have those great multidisciplinary models and have counseling centers that can involve everybody is really, really helpful. Some bigger universities, and again, all of this is kind of a little different now with COVID. Some of it's done virtually, but having those support groups, having different groups centered around healthy eating, healthy self-care, and kind of working all that in, but having a way that when it is identified as a need, that there can be a team, or there can be a strong referral base of where to send individuals when they need help is hugely important. And creating some of that advocacy and that psychoeducation around eating disorders is important too.
Thank you.
And I will mention one thing that I didn't put a slide in here about, but telehealth it's just produced a huge struggle. I don't know if anyone else in here works with eating disorders, but I've seen a huge struggle with the transition to telehealth. When I can, so much of eating disorders is monitoring how my clients are presenting physically. And when I can only see from like the chest up, I'm not getting a good idea of where they are. They can tell me, that they're doing better, and I'm not able to see a lot of that body language, a lot of that physical presentation. And so it's really, really hard to monitor and to treat over telehealth.
I have a question, and if anyone else may have any information too, but I feel like I'm going to reach out to you after this session too. But I'm working on my dissertation. I'm right at the perspective stage. And so right now I am trying to explore eating body image issues amongst African-American women. And so I think right now what I'm trying to find is right now the gap in the literature, and I'm not finding any specialized approaches in regards to working, in particularly with African American women. Just want to know if you had any information, or we could, like I said, talk after the session.
Yeah, I mean, I think you're right. I think that's a gap, definitely in the research. Off the top of my head, I don't have anything. I mean, I'm sure there's some research out there, but I do think that is a gap, um, for sure.
Okay, thank you. At least it helps me to know I'm kind of moving in the right path. Okay.
Yeah.
I have one more question. What
Yeah,
is
sure.
usually your population? Is it more females than males? Because I know you had said males earlier too.
Yeah, I mean, generally speaking, I see more females, but over the years, that has increased with males. I see a lot of male athletes with disordered eating for sure, because eating is so linked to their performance. So specifically, a lot of my runners, but I've also seen other athletes that have those disordered eating behaviors. So I would say generally it's more women, but I think that as it's becoming more researched and more, what's the word I'm looking for, just out there, that more people are talking about it. I think men struggle too. I think it's just always, they've kind of been left, or pushed to the side. There hasn't been that awareness. So as we have more advocacy and more psychoeducation around what disordered eating is and what eating disorders are, I think men definitely struggle with it. It's just, how do we make therapy available to them as well and encourage it?
Thanks for that.
Yeah. Anyone else have questions?
I just want to say your presentation was awesome. I learned a lot of information. I look forward to following up with you. Thank
Thank
you.
you. Yeah, and if anybody, let's see where my screen is. If anybody wants a copy, feel free to email me and I'll send it to you. I'm not going to show them today, but I have a link to a couple of videos. One you can easily Google is when Taylor Swift talks about her eating disorder. That's a great one to watch. And just be aware, social media is huge. I have a 13-year-old daughter, so it scares me in every way. But just the stuff that's out there on Instagram, that is just praising thinness and praising eating disorders is really dangerous and really scary. So just be aware of everything that's out there. And it's kind of working against the work that we do. All right, well, I'll address Jessica's question because I think it's important. How do I educate my teen daughter? Yeah, and that's something that's huge in our family. We don't do the clean your plate club. We don't do the the negative self-talk and negative food talk. We in our family teach that all foods fit in moderation. So we don't disallow sugar. We don't disallow certain foods or certain food groups. We just teach moderation, and we teach that all foods fit. And we teach, especially as they're developing, that they're healthy, that, they're getting exercise, they're having fun, they're eating. But we also, discourage eating when we're bored. It's, I want a snack when I get home, or, when they ask me for a snack, I'm like, are you hungry or are you bored? And so we definitely talk about it, but we don't dwell and we don't label foods as good or bad. And we create that moderation and that healthy environment around it. And I model that for them too. I mean, in full disclosure, I had a baby a year ago. So there was that desire to lose some of that baby weight, but I was modeling healthy eating habits for my kids. So I was never saying, oh, mommy's on a diet to lose the baby weight. It was just monitoring and modeling that, I'm going to eat healthy as well. And I'm going to get exercise, and we're going to have fun exercising together and doing stuff active together. So
Dr. Barbie, and I have two teen daughters, and so what you're saying is so enlightening. I'm often reading about Snapchat dysphoria, Instagram dysmorphia. It's all kinds of things that are out here that I'm trying to learn so much more about, because I didn't grow up with with
right.
but I think it's important just to get more information on that. And even like culturally, not to you don't have to clean your plate. It's actually, I grew up learning the opposite. We weren't even allowed to get up until we finished our plate. And so it's a lot of deconstructing in my mind that I have to do as I'm listening to your presentation. And I'm so glad that there's more information coming and research coming to fill the gap, because I sometimes feel lost trying to navigate between social media and monitoring that and making sure they're not comparing themselves, which is almost virtually impossible.
Right.
And then the balance of the food and how to speak to them about food. And so thank you so much for your presentation, and this information is just, it's changed even the way I think leaving here. Thank you so much.
Yeah. And I think just as clinicians, as parents, like just realizing that we're being watched and we're really modeling for, our kids, just how we even talk about food, how we talk about our bodies. When I'm behind closed doors, like I'm probably really prone to body shaming myself. But I don't want my daughter to grow up seeing me say, oh, mommy's fat, or, oh, mommy has, a little bit too much here, or a little bit too much there, or mommy ate too much, her jeans are tight. Like just watching the way we talk about ourselves is so, so important, modeling for our children. Well, thank you guys so much. Again, please feel free to reach out. And I really, really appreciate you guys attending today. And I hope you enjoy the rest of the conference. Thank you.